Picture this. You're in the ER. A kid is rushed through the doors. The room is absolute chaos. Parents are terrified, and literally every second counts. In these high-stakes moments, you've got to separate the clinical noise from the fatal signal. It's an absolute must because it's the difference between sending a child home safely and a truly devastating outcome.
Welcome to The Explainer. Today we're talking about pediatric clinical tipping points and mastering structured medical decision-making.
Here's our playbook for today. We're going to hit 4 critical tipping points: the air trapping physics, button battery versus coin, pediatric burn kinetics, and finally, the airway gatekeeper. Let's get right into it. All right, section 1, the air trapping physics. We're looking at signal versus noise in the airway.
So imagine a 4-year-old comes in, sudden onset coughing, dyspnea, wheezing. You know his brother has asthma, so your brain immediately goes albuterol nebulizer. But hold on, are you treating the signal or just the noise? Take a look at this x-ray. We don't see the bilateral hyperinflation you'd expect with an asthma flare. Instead, we've got unilateral hyperinflation right there on the right side. And look at the mediastinum. It's actually shifting away from the affected lung. Remember, like 80% of aspirated objects are completely radiolucent. Think peanuts. So a negative x-ray, that's just noise. The real signal is what the object does to the anatomy around it.
This is a perfect example of what we call the check valve mechanism. An object gets lodged in the bronchus, usually the right main bronchus, right, because it branches off the trachea at a much sharper angle. It acts exactly like a mechanical valve. As the lungs expand on inspiration, air slips right past it. But when the kid exhales, the airway narrows, clamps down on that object, and traps the air inside. Boom. That's why a localized fixed wheeze that doesn't clear with the bronchodilator is your absolute dead giveaway signal for a foreign body.
Now, here is a massive execution gap you absolutely have to avoid: the blind finger sweep. If you can't see the object, do not reach for it. Ever. You risk taking a supraglottic object and just shoving it down into a total subglottic obstruction. It's a real nightmare scenario. If the child is still coughing and breathing, your path is clear. Get them to urgent rigid bronchoscopy. But if they stop breathing, that's your cue to immediately step in with back blows for an infant or the Heimlich maneuver for an older child.
Moving on to section 2, button battery versus coin, esophageal emergencies. So what if the foreign body isn't in the airway but in the esophagus? Well, the whole presentation flips. Instead of respiratory distress, unless the object is giant and compressing the trachea, these kids come in drooling, having trouble swallowing, or just flat out refusing to eat. And these x-rays perfectly demonstrate a classic coin impaction. Because of the anatomy right at the thoracic inlet, flat objects like coins will lay completely flat on an AP x-ray, looking like a perfect circle, but they'll appear edge-on in a lateral view. This is where we hit a highly tested dividing line. If that object is a coin, you can usually just observe them for 24 hours to see if it passes into the stomach on its own. But a button battery? No way. That is an absolute surgical emergency. See, the moisture of the mucosa actually completes the battery's electrical circuit. That leads to rapid liquefactive necrosis, and you can get a fatal aortoesophageal fistule in as little as 2 hours. It requires immediate endoscopic removal. Now, as a quick aside, if that same battery has already passed into the stomach and the kid is totally asymptomatic, then you can usually just follow it safely with serial x-rays. But in the esophagus, get it out immediately.
All right, section 3, pediatric burn kinetics and the rule of nines adjustment.
This brilliantly illustrates why you can't just treat a pediatric burn like a shrunken-down adult burn. You know the adult rule of nines, right? 9% of the total body surface area goes to the head, 18% to each leg. But little kids, their heads are completely disproportionate. The pediatric adjustment allocates a massive 18% just to the head and bumps the legs down to 14% each to compensate. If you just blindly apply the adult matrix here, you're going to completely fail your patient.
Which brings us to the Parkland formula for fluid resuscitation. The base math for the first 24 hours is 4 milliliters times the weight in kilos times the percentage of surface area burned. You give half in the first 8 hours, the rest over the next 16. But here's the catch for pediatrics. There is an absolute mandatory add-on. Kids have virtually no glycogen stores compared to adults. So to prevent them from crashing into severe hypoglycemia, you absolutely must add D5 maintenance fluids to that standard Parkland volume.
And here's the dangerous noise you have to tune out: first-degree burns. Think of a simple sunburn. Pain, redness, but no blisters. Never, ever include these when calculating your total body surface area. You only count partial and full thickness burns. If you include first-degree burns, you're going to cause massive over-resuscitation. It's called fluid creep, and you literally risk drowning the patient from the inside out, leading to nightmare complications like pulmonary edema or even orbital compartment syndrome. Just don't do it.
Finally, Section 4, the airway gatekeeper, croup versus epiglottitis. Let's look at two life-threatening upper airway infections where early recognition is literally everything. Look at this AP X-ray of the neck. Notice how the airway just drastically narrows as it moves up? That is the classic steeple sign. It looks exactly like the top of a church steeple. And it's the absolute hallmark of subglottic narrowing, which we see in croup. This matrix perfectly breaks down the two primary culprits. Croup, usually driven by the peri-influenza virus, gives you that steeple sign, hoarse voice, and that distinct barking cough that always seems to get worse at night. But epiglottitis, that's a totally different beast. It's a rapid, highly toxic bacterial infection. These kids aren't barking. They come in with a sudden high fever, a muffled voice, they're drooling, and they can't swallow. You'll see them instinctively leaning forward into a tripod position, just fighting to maximize air entry. And radiographically, instead of a steeple sign on an AP film, a lateral X-ray is going to show you a swollen epiglottis, the famous thumbprint sign, which leads to a critical execution gap. If a kid rolls in drooling, toxic appearing, and tripoding, your gut instinct might be to grab a tongue depressor and take a look in the back of their throat. Stop right there. Never examine the throat of a patient with suspected epiglottitis unless you have an airway expert, like an anesthesiologist, standing right beside you. Poking at that inflamed tissue can trigger a severe, completely irreversible laryngospasm. We're talking total airway obstruction right there in the exam room. Your play here is to secure the airway first, ideally in a controlled OR setting, before you even try to confirm the diagnosis.
Wow, we've covered a ton of ground today. From the physics of a trapped peanut, to pediatric burn math, to the silent ticking clock of a swallowed button battery. By anchoring yourself to these structured mental models, you can cut right through the panic and execute with confidence. So I'll leave you with this. When the next pediatric dilemma comes crashing through those doors, are you going to get distracted by the clinical noise, or are you ready to find the true life-saving signal? Thanks for hanging out with me for this explainer, and I'll catch you next time.